then
This meeting is being recorded.
Brilliant. So a very good afternoon, ladies and gentlemen. Greetings from India and Malaria No More India. I'm Prateek Kumar. I'm the country director for Malaria No More India. And with me, we have a bunch of illustrious panelists who are about to speak on a very, very important topic that is confronting mankind today. Most of us on the panel would know that it was today, way back in 1897, that Dr. Ron Ross in India itself discovered that the Anopheles mosquitoes were responsible for transmission of malaria within humans. And that understanding completely changed the paradigm of how malaria was tackled going forward. There is just some very interesting anecdotes as to how malaria was by far the biggest killer of humankind ever since humankind evolved. Far more than all the wars and famines and other calamities put together. And that kind of puts in perspective how dangerous this disease was, thankfully. We are getting better today. And in the recent past, we have done wonders in terms of handling malaria, especially in India, wherein we have, thanks to the call of the Honorable Prime Minister, decided that by 2030, we will become malaria-free. So we are now at the cusp of something very, very important. The country is undergoing a transformation, not just in terms of how we are fighting malaria, but also in terms of looking at how malaria elimination strategies will now be evolving. So the new 5-year plan that actually is meant to be driving the program from 2023 onwards till 2027, which is the window that we have to take the country down to 0 cases, because the country has to be at 0 cases for 3 years to be declared malaria-free by 2030. And to discuss all that and the way forward, to understand what the priorities for malaria elimination in India ought to be as we look at the elimination battle, we have, with our wonderful partner, with Malaria No More India and panelists from across the country, we are now looking at a possible scenario where the country could be malaria-free in the next foreseeable future. I'm personally not very, very optimistic about meeting the 2027 target, but having said that, the country has a challenge, and that's for all of us to look at. So Malaria No More India and HEDL, we come together to bring you a range of participants and experts who are stalwarts in their own spaces and would be very happy to give their opinion on how best we can tackle this disease going forward. To kickstart the discussion, we have between us Dr. Ayushman Mahapatra. He's an eminent epidemiologist and social scientist. Dr. Mahapatra has experience in designing and managing multi-partner networks and multi-site epidemiological research in several roles that he has played in the country. I would request him to kickstart the discussion today by enlightening the panel on, what is it that he sees would be the role that he personally, in his experience, given the background that he has on malaria elimination, and how does he see that the country can really pull it together to meet the elimination challenge. So over to you, Dr. Ayushman.
Thank you, Mr. Prateek, for this introduction and for having me on this panel today. I absolutely empathize with what you just now said, that how do we meet this target, and also together, we do it together. So clearly, it's a multi-stakeholder mobilization exercise, and not just mobilization, it has to be an engagement exercise. Because what we are proposing is not just to get to 0, but also sustain it for 3 years. That's something quite contextual at the moment, because India is gradually shifting from just being a service-oriented country to a product-oriented country. So, and of course, we have a massive market for consumerism. So when we are pitching malaria-free interventions as commodities, sort of like people must own them up, use them, and sustain as a behavior change approach going forward. That means we must appeal to the interests of all the stakeholders involved here. Clearly, there is commitment from the highest corridors of power. And technically also, we are quite mobilized. But we must understand that malaria has been a long, it's been a long problem. And it has been among us for so many centuries. And we still are sort of struggling to adequately define this complex problem. So this problem is not adequately defined because still we experience hotspots, and solutions also must be contextualized. So this classifies malaria as a typical wicked problem, where we don't really know to what extent we can solve it, but then we must solve it to a level of satisfaction. Of course, each time we solve it, the goalpost is likely to get revised. Designing human-centered interventions in such situation is important. And that again requires us to empathize with the people who should own up. So the last person in the line, the most vulnerable communities, must own up the interventions we're proposing. And at the same time, we must also ensure that it's not just user desirability that is driving our interventions, but also business viability and technical feasibility. All should go hand in hand. And then we also manage to implement in a sustained manner at scale so that we test the effectiveness, or at least improvise in case effectiveness is clumping in small corridors. So what I'm trying to drive home here is that it requires massive engagement and contextualizing our interventions going forward. We have learnings coming up from across the world and of course from within India. As you said, India has made very good progress ever since the discovery by Ronald Ross, and recently the commitment to come down to zero by 27 and then sustaining to 30. Though ambitious, seems doable because we have that capacity in country. Back to you, sir.
Wonderful. So if you could just give us a few specific examples of what kind of interventions do you classify as being human-centric? One would argue that whatever we do is basically for mankind at large. But if you could just give some nuances of what makes an intervention more human-centric than otherwise, that will really be useful for the audience as well.
Yeah, so human-centric interventions in the context of malaria are not adequately published from India yet, but we have very good evidence coming from Africa. So, and why Africa? Because somewhere human centricity is driven by emotions. That means you need communities who are already emotionally directed in some other direction, or maybe they can be easily influenced through emotional pitch. That means communities where local leaders hold a very strong stand, where their voice matters to a large extent, and also some myths and some practices must be dispelled, and some behavior change management intervention must be implemented. So, for example, when we're proposing insecticide-treated mosquito nets, that means we are proposing a net, but then the end user has to use it. And it has been seen that in instances in a paper from Ghana, what I could come across, they said that the community does not like the mosquito nets because they are not aesthetic, and also getting into the mosquito net is clumsy. And what they did is by talking to the people over there, they co-designed a mosquito net which is aesthetically appealing to them and had a zipper to get in and out of it. Some of them also complained that the weather is too hot, and also when you put on a mosquito net, it becomes too dark. So what they did is they put some arrangements of a solar operated fan inside the mosquito net. So those are simple interventions that really go a long way. Another study said that when we are promoting indoor spraying, they would prefer local people to come inside their home. They would not want usual frontline malaria workers to get into the home and spray. So those kind of minor tweaking improves the acceptability of the interventions leaps and bounds. And especially in the Indian context, when you're talking of technology and using ICT and other methods, and of course, putting up surveillance in these communities, you need the participation, and not just participation, the involvement and cooperation from the people. So those are certain interventions which must be considered.
No, I'm so thankful that you came up with these concrete examples, and working in the field with under malaria no more, we see a lot of these practical nuances defining how interventions have to be designed. One of the very stark feedback we have, again going back to LLIs, just because you mentioned that, was that the community, even after being told that you're not supposed to wash it often or dry it in the sun, within a year or so, they get all their washes and the sun and whatever. So, if in such a case, I'm sure you can imagine what the efficacy of the LLIN is. And it's like a 3-year thing, which gets literally consumed in a year's time. And then, so you do have an LLIN, and apart from the itching and, other discomforts that they keep repeating all the time. So all these feedbacks extremely important as we design interventions and make it relevant for community. So thank you so much, Dr. Ashma. We'll keep coming back to you because this panel is going to rotate as much as possible here. Let me now turn to Dr. Dulai. Dr. Dulai is a distinguished physician, and he's specializes in geriatric medicine, family medicine, diabetology, etc. He's also worked in the RG Medical College. And he is, today he's being drawn into this conversation on a very, very important topic, where we feel that, the malaria battle, especially going forward and looking at the audience participation today, has been very, very confined to just the public sector. Having said that, there are a lot of cases that definitely go into the private sector. And somewhere, the national program has not managed to truly integrate the private sector into this big battle. And that's something that we are all concerned about. I just need Dr. Anirban to, just give us a perspective on a physician's perspective on what are the challenges he foresees in malaria management. Dr. Anirban, please.
Thank you so much for inviting me on this platform. So it is an honor to share my experience as well as the role of physician, or rather I better to say that is a perspective of physician for diagnostic, treatment and management challenges during malaria cases, during when he or she is getting some malaria cases. So what are the challenges they are getting in their regular practice? So if you give the permission, I will share some screen.
Yeah, I think, yes, go ahead. Yeah.
Yes.
It was there right now. Yeah, we can see that, Dr. Anirban.
Yeah.
Maybe you can do a full screen? Yeah.
So yeah. Thank you. So just I want to mention here what are the challenges in the management of malaria in a physician's perspective. As a public health physician and public health specialist, we have to come across a lot more of cases of malaria, a lot more of cases of fever, undiagnosed, and in some spaces, in some time it will get some kind of worsen. So if I consider these things, there is World Malaria Report. According to World Malaria Report of 2019, India represents around 3% of the global malarial burden. And if I consider the India has a vision of malaria-free country by 2027 and elimination by 2030, as already you have mentioned. So what are the challenges in the public health perspective? This population movement, insecticide resistance and shortage of skilled human resources are the major challenges in malaria control, and we'll discuss further among all of our panelists will come across on it. So what are the diagnostic challenges? So in when there is a case of fever or fever for 2 to 3 days, high rise of fever, some kinds of chill and rigor is there, some specific trend of fever. So then we need to highlight whether we need to do the malaria test or not. And there is a major issues that delay in diagnosis. The people the doctor or the physician first prescribes some kind of antibiotics, some kind of fever medicines, medications, etc. And then after 2 to 3 days or 4-5 days of crucial period, then the malaria tests come, and this is going to be test positive. So this is a delay in diagnosis, and there are some other areas where we can highlight, we can put some light. That is, despite high sensitivity and specificity of Plasmodium falciparum infections, RDT has limitations. That is, in low density parasitemia, the many are less sensitive for the Plasmodium vivax infections, and their ability to detect Plasmodium mobile and malaria are actually unknown. Another thing is malaria diagnosis is getting complicated when there is immunity to malaria is there, actually the asymptomatic infections. And in a symptomatic patient, in a febrile patient, no existing malaria diagnostic test can distinguish the venereal illness from other parasitemia with the concomitant fever or another cause. So if I want to give stress on whether the challenges of the treatment, so we need to focus is the first of all is, we may say that there is a treatment failure. We know the term is in malaria. It is said that it occurs when a patient is diagnosed with malaria, fails to improve on a given treatment that is recommended or management plan. And this treatment failure can have some kind of challenges, then create some kind of challenges for the physician. First of all, delay in starting the antimalarial therapy. Many times we see that there is delay in starting of antimalarial therapy in a malarial infection that gives the disease a chance to progress from simple to severe. So that can be stopped, that can be checked by a physician's point of view. A delay in treatment may be caused by the healthcare workers, maybe due to the local ground level health workers, or maybe it kind of the ignorance or negligence from the patient's side. Another one is incorrect doses. The ideal drug doses has been given in all the recommended textbooks as well as the national program book. So we need to just highlight, we need to just revise these doses. So there may be overdose, there may be underdose. We need to be very specific on the dosage side. Then failure to elicit a history of recent chemotherapy. So what does it mean? There is a two-sided factor. On the one side, the patient may not volunteer the history of the treatment of the medical records of the same. On the other side, the medical worker may be due to pressure of the work or time, they fails to elicit the treatment history. So that is very much important. We need to have some history from the patient. The failure to prevent cumulative effects of antimalarial drugs, that is that all the drugs have effects on normal functioning to the body, and the antimalarial drugs are no exception. So cumulative effects are like nausea, vomiting, hypoglycemia, maybe hemodialysis, and these kinds of things may hamper the any treatment, may hamper the adherence to the treatment of the patient. Then unjustified withdrawal of an antimalarial drug. There is also very much important for a physician. This causes treatment failure because that is not given adequate time to react or act. The failure to review antimalarial treatment in a deteriorating patient who is getting severe, you need to escalate or you need to be very specific about the doses. Multiple diagnosis on the patient. What does it mean? The multiple diagnosis may cause a health worker to concentrate on one disease only at a time, but other diseases may deteriorate, so that the holistic approach can be ignored. The substandard drugs, this is a very much important in a Southeast Asian regions, specifically low-income countries. There are so many substandard drugs, so the drugs should be very scientifically made and authorized. There is true drug resistance. There are several papers, several discussions over it over the time. So we know that what kind of your chloroquine or sulfonylurea. So these drugs can be get resistant in several areas. So we need to be very specific where we are practicing. The failure to recognize and treat severe anemia. So it is the catch point where there is the normal normal patient with fever, with malaria. When he goes to the severe state, just catch the time and treat the severe anemia accordingly without delay. Failure to look for the hypoglycemia, we have already mentioned some kind of severe the symptoms of severe diseases like pulmonary edema, aspiration pneumonia, acidosis. So we should not delay our treatment and should start the hemodialysis if required in cases of severe malaria. So errors in management can be we can give a brief emphasis: this inappropriate route and schedule of anti-malarial administration, erratic cessation of the treatment, errors in fluid and electrolyte replacement that can causes heart failure if we get excess. If we give it less, that is causes dehydration and there is AKI. The use of inappropriate drugs like chloroquine alone in the areas of high chloroquine resistance, over treatment or overdose is very much problematic. The use of potentially dangerous drugs like steroids should be very cautious using these steroids. So we need to focus, as a physician, we need to focus these things when we are treating a malaria patient. This, first of all, the proper diagnosis on time, and the start appropriate treatment without any delay. Prescribe or administer drugs according to body weight. This is another important issue. We are seeing many patients are getting very low dose or not according to his or her body weight. So that should be mentioned, that should be highlighted. Using the correct doses or recommended time period. So what kind of medicine like chloroquine, primaquine, etc., and when and how much, for how much days you have to take, you need to mention it clearly and you need to follow up. So continuously monitoring the progress in the treatment of your patient to avoid the anti-cumulative effects. There are some kinds of side effects, adverse effects. So you need to monitor a follow-up so that the patient cannot stop the drug in between. The stabilizing all your patients, like that is most important, is in case of there is any kind of adverse situation occurs, you need to stabilize it first. Treating any complications that arise in a timely manner. Always exclude the possible differential diagnosis. Don't stick to your diagnosis that is malaria, no other co-infections is there. So don't be silly on that. Not withdrawing drugs for just cause, okay, the fever has gone, just stop the medicine. Don't do this. You all know that every time we are when we are giving the training to our physicians or medical officers in different hospitals, we are many times we are saying these things. Starting all patients able to take and tolerate oral medications on oral drugs, using the drugs recommended according to the resistant pattern observed in your area. Very much important for our country like India. An appropriate obstetric intervention in late pregnancy. So this is a specific group, the pregnant mothers. So we need to be very much specific and need to be very much restrictive regarding these pregnant ladies. There is the treatment guideline is extensively written in the program books or their programs. So I think these are the priority areas we need to focus. We need to be very much specific, as well as whether we are lacking, whether the physicians come across the challenges we have discussed here. I hope it will help for planning or treating the patient.
Thank you so much, Dr. Anirban. I think from a physician's perspective, the list of challenges that you enumerated are spot on. Just wanted to draw attention of this group to the other spectrum of how treatment is really happening. All of us know that it is our frontline ASHA workers who are doing a lot of diagnostic treatment as we speak, and most of the complications that you talk about are even difficult for doctors. And personally, I've come across a lot of people who have handled malaria cases, but may or may not have the full nuance of it, the details of which you have gone into. Now, in such a scenario, how do we see this dichotomy? And of course, I've not even talked about the non-registered guys, the quacks and others, especially when you work in tribal settings and settings where the health systems are very weak. Somewhere this duality needs to be taken care of. So just some thoughts, from you, Dr. Anirban, as to how do we set this duality right? We still see the public sector doing stuff. The private sector, of course, is treating malaria, but not enough emphasis given to just capacity building of them to get real updates. And then you have the quacks, and then you have the ashas, the AIIMS, who are kind of also delivering the whole thing. So just a few thoughts around that also, please.
Yes. So it is very much important whatever you have emphasized right now. So there are ground level workers, that is your ASHA, and they are giving some malaria tablets. They are keeping the malaria, the chloroquine tablets along with them. And whenever there is a malaria detection through this your rapid detection kit, they are giving this malaria anti-malarial tablets to the patient. That is a separate issues, but we need to highlight the things where there is the diagnosis and the treatment delay occurs. There are some parts there is a diagnostic delay. We need to be very much specific about through our ground level workers as well as quacks, because there are so many areas in the tribal, as you have mentioned, as well as in villages, where the patients are first go to the quacks first, and then they are referred to the other. When the patient getting severe, they are referred to the higher setups. So there can be a possibility, there can be a chance that we can train these quacks also, because there are so many illnesses in and around us, and during this COVID pandemic also, the state of our West Bengal, they have trained so many quacks regarding this first symptomatic management, as well as whether the treatment cannot be delayed. So these two issues was highlighted many times, because in our state, Dr. Sarkar, Dr. Mahapatra, they knows the Sundarban areas and these Purulia, the hilly areas, they're actually remote places. And in their places, these places, there is actually the scarcity of the doctors, as well as the scarcity of comparatively scarcity of the trained health personnel. So some kind of basic training can be given to the quacks or the doctors other than the modern medicines, so that they can check or they can just diagnose it early, and whether they have to refer it or not, they should decide. And the second one is, as the anti-malarial drugs are available in the market, as well as along with the ASHA workers, so the exact dosing, it should be very much specific, so that we need to be very much focused regarding this advocacy, regarding this IEC campaigning to the patient, to the endemic areas, so that patient should not stop the drug in between, or should not stop the drug for any kind of adverse effect or side effect they're experiencing. So if we can give the focus to these things, these areas, we can get a better things. At least we can stop the resistance. At least we can we can prevent the delay in the treatment, and we can prevent the severe diseases.
Yeah. Thank you, Dr. Anirban, for being so candid about inclusion of other people, because I understand it's a touchy topic for a host of reasons, and we all understand the limitations of such an approach. But at the same time, India being what it is, and there are pockets which, we work in a couple of districts in south of Odisha, Koraput and Malkangiri. Yes. You have the entire district where there's hardly any MBBS doctors. So, and these are very high malaria case endemic regions. So, how do we really address that? So thank you for bringing that in. And of course, this is a larger debate. Sure, please.
I just want to conclude with the remarks that we need to call all the different sectors, different associations who are working in different levels, and general practitioners, with the practitioners, public health practitioners. All the platforms should go together, and for a different, as we have already, Indian Medical Association, we have already taken some kind of regular day-to-day CMEs for the tuberculosis. So we can have the malaria part, because we are experiencing so much of physicians and young physicians, they are not actually, they are not aware of the actual malarial treatment when they are practicing, when they have started the practice. So we need to be very much specific, and we need to involve the other associations, on, including the government and private sectors, so that these kind of your enhancement of the knowledge can be continuous. Thank you so much.
Thank you so much, Dr. Anirban. Thank you for your very candid remarks. Let me now take the discussion into a slightly different space, and I now request Dr. Gopa Kumar to come in. One of the things that malaria, unfortunately, is not getting enough attention on is the economic impact it creates. Now, of course, very fortunately, the death rates have gone down. But the fact that people are suffering from malaria, and there are many such cases, so there is obviously an impact that is coming onto the society, because you lose man days. There are a lot of cases which, to my mind, kind of go undetected, because as Dr. Anirban was also mentioning, that there's a lot of delay in just people coming into a diagnostic setup. And you live with the fever, and until you hit a point where things cannot be managed, you possibly go in for malaria. So the whole concept of early detection and testing takes a hit there, and there are man days being lost, and so on. So Dr. Gopa, maybe I'll just do a quick introduction of you, Dr. Gopa, and so he's got tremendous experience in managing and providing technical oversight and strategic direction to large scale projects. And has worked with a whole bunch of state governments and donor agencies like the EU, USAID, DFID, World Bank, etc. I would especially like to invite him on just talking about the malaria burden and forecasting around what would be the economic considerations as we try and eliminate the disease from the country. Dr. Gopa.
Thank you, Pratik, for giving me this opportunity. Good evening to all my fellow panelists. Can you hear me properly?
Yes.
Okay, so as Pratik said, I will be bringing some different perspectives into malaria elimination, because our topic is National Strategic Plan for Malaria Elimination Phase 2. So as you know, we had long history of malaria. Pratik said we have centuries, malaria parasite is here, and we have much more research on malaria. But unfortunately, we are unable to eliminate or end malaria cases in India. If you go to the history part of malaria, we started the malaria control program in 60s, and around the 70s, we could almost, we reached up to the zero malaria cases. But there is a relapse. I don't know why we could not continue that, and then malaria relapse case was in a much higher scale compared to the previous decades of 60s, 40s, etc. So there is some kind of sustainability issues with malaria control and malaria elimination program. As you all know that by the year 2016, global technical strategy made a guideline for the how to eliminate malaria, how can you prepare your national strategy plan, etc. for the period 2016 to 30. If you follow that, 35 such countries are supposed to eliminate malaria by 2030, and by the year 2017, we also got activated, and we also prepared a national malaria study, NSP, National Strategic Plan to Eliminate Malaria 2017 to 2022. So we had this malaria NSP for phase 1 at that time, and there are a lot of good write-ups and activities were planned in that. But unfortunately, now we are almost going to end year 2022, and many of those objectives which we written 5-6 years back remain unmet. So now we are in a very critical situation that, you do not have much time now. See, now we are coming into the NSP2, which will be starting from year 2023 to 27. And we need to have by zero indigenous cases by 2027. And then these 3 years, is a lock-in period. No malaria should be reported. Indigenous malaria case should not be reported, so that WHO can give us certification that India is malaria free. Our neighboring country, Sri Lanka, really eliminated malaria a few years back. So where things are going wrong with us? Do we have sufficient money? Do we have sufficient technology? Or do we have enough people involved in this? Is there any convergence of ministries and departments? Where things are going wrong? So now we are, it's a time to have kind of, retrospect analysis that, where we were going wrong. One very clear thing which came out is that, business as usual is not going to work for the period 23-27. You just cannot say, audit is praying and this and that is not going to work. So we need to have out-of-box thinking, we need to have more involvement of people, and, you need to have more, effort at the case reduction at the source. Case reduction at the source means, where the malaria is spreading. So you need to address why this area is having high endemicity, why not in other area, what are the factors influencing that, do research on that, and address that. As Pradeep said, malaria is not an all over India phenomena. Malaria is only in pockets. Where are these pockets? Where there is, forest, where there is, marshy place, where there is, water stagnation and, water stored in different containers, and then malaria, spread all those places. So which are these pockets? Basically, Tripura is one of the high burden, northeastern state, then Mizoram, then parts of Chhattisgarh, and then parts of, tribal areas in Madhya Pradesh, and then Odisha. Odisha last 1 year drastically reduced the malaria burden. So normally what we do is we classify the districts and states based on API. So API is only at the larger level it will be working, but API at the subcenter level, at the CHC level does not work. So we need to rethink classification of the high burden districts, not based on API but based on the average malaria burden for the last 5 years. That is a kind of thing we can predict that whether this district can be brought under zero malaria case in next 3 to 4 years. API is not going to help us. So this kind of out-of-box thinking we need to do in the coming national strategic plan. We are debating on that. Number one is source reduction, which I said. Source reduction is basically you need to find out where are these hotspots and why this is becoming a hotspot, or we can address it. All these clinical aspects will come under the source reduction. Second one is, in order to do so many activities, now we are thinking about delivering or dispensing malaria tablets through drones. So drones will be used in that case, do we have enough money? So the second pillar of malaria elimination is, do you have sufficient funding? Or do you know how much money is required? Now we all say that we need to eliminate malaria by 2027, right? Everybody agreed? So now question is, in order to eliminate malaria by 2027, do you have sufficient money? Now you are having only money to buy microscope. Now you have to buy drones. You have to bring in artificial intelligence. You have to have kind of, mosquito manipulation so that, it can be, we can stop the breeding. So these kind of things are new activities which we need to include, and then it is our expensive activities. So do we have sufficient money? So there are technologies used in various disease elimination process. If you input all those information, you will see that by 2024 what money is required to eliminate malaria by 2027. So we will say 23 year 1, 24 year 2, 25 year 6, like that, because all the activities will not be carried on for year 1, year 2, year 3, etc. Some activities need to stop by the year end of the first year. Some other activities will start by the beginning of the year 2. So all this input data we need to put so that we can have the malaria, forecasting. Once you know that by 2027, you need $10 billion $10 billion you need to eliminate malaria from 23 to 27, then only you can do fundraising. Fundraising through domestic, increase in the domestic funding, increase in the international funding from GFATM, Global Fund, BMGF, etc., and also there are a lot of CSR funding available. So now you go to a donor, say that I am going to eliminate malaria by 2027. This very good activity. So how can I help you? So you have no answer to that. You say that my target is 13 billion USD, and whatever you contribute is important. So then they say, okay, I can contribute 13 billion, I can give you 1 million USD. So you have a pool of, so that is how we need to do fundraising. So we need to have that forecasting of, malaria elimination, funding requirement, then only you can do, effective fundraising, and this will form one of the key advocacy tool and key ask for national and international donors. The third main, lacuna of our national strategic plan earlier and other disease control program utilized it, and they made the success is the community involvement. So when community owns it, they will also involve. Now what is happening is we are giving them, 2,000, 2,500 rupees, LLINs. They are using it for fencing. They are using it for fishing, fish, and so many other purposes, like, giving it as a dowry, and they are keeping it. And they also don't know how to, roll the LLIN, which is so expensive, and they don't know how to wash it. They don't know how to dry it up, etc. And they say that I got it, last month only. By the time half of its shelf life is over. So these are the kind of field level issues coming up. So we need to address this, how we can, and also now there is a recently thing is that these vectors are resistant to LLINs also. So how can we have a new technology involved in the manufacturing of LLINs using different chemical combinations? So we need to think out of box. We need to have innovative ideas, and we need to have some something business as usual is not going to work. So what are the new innovations which we need to do? So I already mentioned. So now coming to the second pillar or sub-pillar, there are 4 sub-pillars for the national malaria elimination program if you want to be successful. One is political commitment. So why the HIV/AIDS came much later, but it is under control. Our youngest brother, COVID-19, came 2 years back, and a lot of money came in, a lot of activities came in, all the sufferings. We end up in a lockdown. But why this is not happening for other diseases like malaria, tuberculosis, which are much older? And malaria, I already said, it is not all over India phenomena. It is only for a few pockets which we can really address. So political commitment we need. Political commitment means not only the Prime Minister declaring it, it is coming from the elected representative at village level, sarpanch, gram pradhan, to MLAs, to state level ministers, to MPs, and then coming into the Union Health Minister and Prime Minister. So everybody should be involved. Community should be involved. There should be community malaria volunteer. In my village, if somebody is having evening chill and fever, if I can have access to the ANM or ASHA, I say that my neighbor is having this kind of symptoms, possibly malaria, somebody can rush and do an RTG test, and immediately it can be done. So malaria diagnosis and treatment is not rocket science. You don't need too much of medical aspect into it. I know the most of you are doctors, so but practically speaking, it is if you involve community, like Pradeep said, in my TB program, I trained quacks and other people how to diagnose tuberculosis and make treatment. There are standard protocols for treatment for malaria, TB, etc. If the quacks are trained and these are the symptoms, you at least refer to the nearest doctor or qualified medical doctor. I think half of the burden can be solved, and we can initiate the treatment on time. Second is strategic information. Any planning we need to have clear-cut data on that. Unfortunately, we do not have any clear-cut data collection and transmission mechanism. There are something like 9 to 12 forms which the ANM and the ASHA worker needs to fill. Other 3-4 forms they need to fill. But if you see the forms, there are repetition. Many times it is repetition. By the time it reaches from sub-center center to national level, I don't know how much of data is losing in between and what kind of quality data we get. So we need to have a geocoded scan kind of mechanism wherein if you put a barcode in the RDT kit and positive cases scanned and uploaded immediately, we will get a real-time accurate data. So that is missing, and in this national strategic program we need to have geocoding of this kind of information so that I can predict the epidemics. If from some village I am getting a lot of cases in, that means it is a precondition for a epidemic. So I can do epidemic preparedness in advance. For example, a state in Tripura, there are 8 districts, but Dalai got national level highest number of epidemics and malaria and deaths. But another district in the same state, West Tripura, there is hardly any malaria. So we need to do the deployment of malaria staff from high burden to low burden. But the question is, we don't know which is high burden. We use API. API is not the correct indicator to identify the high burden districts. You can have API at the state level, not at the district level and below. So we need to redefine, the new indicators to identify high burden districts. Then only we can have. That's what I said, strategic information. Then the third sub-pillar is better guiding. The training and the capacity building of the frontline workers and the technicians and the doctors, etc. And as Pratik also said, around 70 to 80% malaria cases are treated in the public sector, government sector. I was in Tripura and I met one private doctor there in Tripura who used to treat malaria thing, and he frankly told me that, look, I don't know really much about malaria, but when people come to me, I am confused what to do, what not to do. So I prefer them to the government hospital. So that is the thing, So government system are already in place, but people are not reaching out to government. So we need to have some mechanism to reach out to hard to reach areas like Zoom cultivation. People 6 months, 8 months out in the forest area living their children, family, in the mainland, and they do for cultivators, Zoom cultivators. Highest malaria burden is among those community. Why can't we do some planning for addressing those things which we know? We have up to drones. So we need to think something about, if we want to end malaria or eliminate malaria by 2027, we need to rethink. And then, Bharat Swachh Mission. There are so many things. Jal Shakti Ministry got a Jal Mitra in every villages. Why can't he go and tell people that don't accumulate water in the coconut shells and tires, etc. This is a breeding area for the mosquitoes. But we need the convergence of the ministries to end malaria. Otherwise, what happens is only one national vector-borne disease control program and a few staff, and then little bit money. If you see the global fund, funding to malaria is go on declining. Say why it's go on declining? Because they say that whatever money I gave, they did not utilize. So if you see the malaria, allotment, it is very high, and the disbursement less, and then expenditure or utilization low. So there is a big gap between expenditure and allocation. So malaria funding is going down. Why malaria funding is going down? Because unutilized the money remaining there. Why money is unutilized? They say that, sir, only 2 months before I get the guidelines how to use the money. So we need to streamline from top to bottom and bottom to top some kind of information flow at the right time in coming NSP period 2. So these are the various points. And my last point is that if you want to eliminate malaria by 2027, zero indigenous cases by 2027, we have to use anti-malaria vaccine. Many countries in the globe, especially African countries, successfully utilizing malaria vaccine. We need to introduce malaria vaccine in India too, sooner or later. Otherwise, we will not be able to reach out to our target. Second thing is, in many countries now, single dose malaria treatment is going on. This will reduce the, treatment adherence and compliance, etc. Because only one dose. What is happening is nobody is willing to take 13 days. After 2-3 days, they are leaving the medicine, and it is becoming drug resistance. So we need to do this single dose advocacy, and massive fever testing camps we need to organize in the coming years. These are the few steps we need to include in the coming national strategic plan 2. And then I hope that I am very optimistic. I think that if you do all those things with the cooperation of public-private cooperation and community involvement, we can really end malaria 1 year before 2027. Thank you so much.
Oh, thank you for ending on a very optimistic note, Dr. Gopa. I'm sure your inputs are being well taken by the drafting committee of the new strategic plan. There are a lot of options, but as you mentioned in your deliberation as well, a lot has to depend on political intent and the will, which normally gets translated as funds into a program. And currently, the level of funding that the malaria program enjoys or does not enjoy leaves a lot to be desired. And at the current rate, I'm not very optimistic, but I hope that the new strategic plan spurs the government into action, and we have something really something to look forward to on the elimination battle. This kind of just brings me to a point where I'm so sorry I never introduced our partner in this program, Clearnet, which is the largest live CME and doctor-generated content platform in the country, with a presence in all cities and rural areas included. So thank you, Clearnet, for spreading the word and getting participation onto this platform today. We, as I mentioned earlier as well, we firmly believe that the private sector has a fantastic role to play going forward. Unfortunately, it has still not been included in the manner in which they could be. And again, going back to examples of HIV, TB, and others, the real success was attained when private sector got firmly entrenched and included into the program. So that's something that we all hope and pray that the malaria program also kind of imbibes and takes forward in the right earnest. Unless we do that, we are not winning the elimination battle. Of course, the multi-sectoral approaches are all fine, but if we have to set our house in order, get the medical fraternity to fight as a united front, and the rest can definitely be brought along. I'd also like to mention that we are recording this session, and there'll be certificates distributed within a week after the conclusion of this workshop. So please, whoever is on the platform today will receive the certificate, and thank you so much for your participation. Let me now turn to Dr. Harsh. So Dr. Harsh is a good friend and a young doctor who's currently the Associate Director and Country Programs for the Asia Pacific Leaders Malaria Alliance, APILMA. He was recently, just before this job, he was heading the Mandala program that a lot of you might be aware of, where he did a fantastic work leading the malaria elimination and demonstration project in Madhya Pradesh. It brings in a lot of experience of how the program is handled at the last mile and now at an advocacy level. Dr. Harsh is coming up with a very interesting topic where he would be speaking on, how and why must the onus of malaria elimination go beyond health systems. So maybe a straight segue from what Dr. Gopa mentioned, that this has to be a multi-sectoral approach. So over to you, Dr. Harsh, for your thoughts. And may I just request people to confine it to about 10 minutes, because we'll be running short of time otherwise. Thank you so much.
Thanks, Prateek. And thank you so much, Dr. Gopa, for beautifully setting up the context for my talk. So as Prateek mentioned, I'll be speaking a bit about the onus of malaria elimination must transcend beyond the health systems. So the topic is self-explanatory. I think you know what it means, but what do we need for it? And what does it consist of? So 3 things I would like to point out here. Number 1, the commitment of malaria elimination was by the Honorable Prime Minister, 0 indigenous cases by 27, and which translates to elimination by 2030. Number 2, the commitment was by the Honorable Prime Minister. And number 3, the commitment was by the Honorable Prime Minister. The reason I'm repeating this, the commitment is not just by the Honorable Minister of Health and Family Welfare. Then why does it feel like that malaria elimination is the only responsibility? It's only responsibility of the Health Ministry. We don't see any other ministry talking about it. We have the recent example of COVID. It was an all hands on deck. Everyone came together. But when it comes to malaria, is the health minister's issue. Why this is happening? The commitment was by the prime minister. He is not the health minister. He is the minister of all the ministries, the entire nation. Then why has this been translated to just one sector? So this is a problem, honestly. The reduction of malaria cases in India is remarkable, no doubt about that. There were some debates around whether the data is right, it is wrong, I don't know, but there is definite decline. We recently had the malaria program review where it was validated by even visiting the private sector that yes, there is a decline. We might also say that we are in the last mile of elimination, barring a few states, but we are mostly in the last mile of elimination. India is the only high burden to high impact countries in the COVID-19 era to have reported a decline in cases. Something to be happy about, I'm sure. But what our experiences from other countries tell us, the last mile has the longest tail. We need a whole of society approach to address this challenge. And as Dr. Gopa has just set up the context, there is a new NSP, the National Strategic Plan, under development. And we are working on developing a multi-sectoral partnerships, differentiating advocacy from social and behavioral change communication. Yes, those are two different things. Somehow they all get jumbled up on the field. But when we say the onus must transcend beyond the health ministry, what do we mean by that? Do we have any concrete steps? Have we outlined any concrete activities? We have, in fact. We have the Ministry of Tribal Affairs. We know for a fact that majority of the malaria cases are still concentrated in the tribal areas. We have an entire Ministry of Tribal Affairs sitting at the helm. Why don't we use their help? Why don't we use their help to generate evidence against specific tribal populations? For example, I would give you a recent example. Prateek is here, Kaushik is here, Dr. Tandon is here. We were designing something for malaria, and a suggestion came, why don't we use some tribal artwork? And the recommendation was, you cannot. You think tribes are just one, like it is just one community with one symbol. It's not a religion. There are more than 600 types of tribes in India. They all have their own cultures. So what we definitely need is, what are the socioeconomic indicators that affect these different tribes according to the malaria prevalence, and map these out and leverage the networks of the Ministry of Tribal Affairs to address this. We have the Ministry of Home Affairs. We definitely need, in the era of last mile of elimination, when our neighbors are also working towards elimination, Bhutan is there, Nepal is eliminating by 2025, the Ministry of Home Affairs will be instrumental in setting up the border posts to screen migratory populations at state and national level. We can leverage the existing COVID-19 screening systems. At the state level, we have the entire workforce of the home guards ready to be deployed for this activity. We have the Ministry of Environment, the forest climate change. Why do we need this? We keep on hearing it's forest malaria, we cannot get inside these national parks, we cannot go inside the sanctuaries. How do we access the forests? Why don't you use their services to do that? It is not such a hard thing to do. We have examples from my project only previously in Mandla. We have done that. We simply walked up to the field director of the Kanha National Park and we asked him, can we screen your staff living inside the national park? He said, go ahead. It's really not that difficult. We can leverage the Ministry of Education to create youth champions. We can target the middle school health education programs. We have the Common Services Center platform. Easier would be to understand the cyber cafe types of things that you see in the villages where they say we can make your Aadhaar card, we can provide you printouts. So those platforms come under the Ministry of Electronics and Information Technology. It's such a beautiful system. We already have it placed at the village level, which can be leveraged for malaria prevention and treatment messaging. We have the Ministry of Railways, the Ministry of Defense. I need not talk about the extensive network of the hospital network and the facilities that both of these ministries have. And last but not the least, we have the municipal corporations. We keep hearing what is the role of these corporations in malaria elimination. We are doing fogging. We are targeting the adult form of the mosquitoes. We are focusing on treatment. Is somewhat translate, not to sound very, pessimistic, but it sounds like we are still keen on investing too much in tertiary health rather than investing in primary health. What does primary health mean in this case? It simply means source reduction. We had all sorts of fines and duties when the COVID-19 pandemic was in force. You don't wear a mask, people will fine you $500 at a traffic light. And those are simply volunteers. I don't know if they were getting paid, but they were happy to do that. But why cannot we have something similar for malaria? The involvement of municipal corporations becomes very valuable in these activities. So there are many more examples of non-government organizations, the civil society organizations, even the housing societies. Those are the first touch points. If you want to do source reduction, the Resident Welfare Association, the RWA, can take care of source reduction with its own periphery. They are registered bodies. They have a responsibility. We have corporate social responsibility. We have many such platforms. So in the interest of time, I'll stop here and we can take up more for discussion at a later level. Thank you.
Thank you so much, Dr. Harsh. Yes, again, I mean, going back to disease control programs that have been managed better in the past, intersectoral collaborations have been the way forward. So private sector, intersectoral, all these go hand in hand, especially in a country like India where the resources are scarce, and if you look at a typical, the space or the human resource available in the health sector, malaria is anyway low priority, and within that to work on the elimination battle is going to be something, unless and until we include a whole range of stakeholders who can join hands and work towards the common goal. Thank you so much, Harsh, on that. I now turn my attention to Dr. Kaushik, an eminent colleague of mine and the director for IMAX with Malaria No More. He'll tell you more about what he does, because we all struggle to make sense of what he does. But requesting Kaushik to quickly take us through some of the innovations that that he feels would be important inclusions into the program if we really have to even think of elimination in the way forward. Over to you, Dr. Kaushik.
Thank you so much, sir. And it was a pleasure listening to everyone right from the beginning. Basically, I see this particular panel as an exception in our entire series that I have witnessed and I have been part of. So as Pradeep said, I simply these days say that I do digital transformation. I mean, I spend my career using data to find new angles to view health security and access problems and design strategies and approaches to solve those problems. So, malaria is the great grandfather of public health. It's one of the oldest diseases, as many have said. And the problem starts there. Why the problem starts there is the legacy is huge. In fact, many of you know that malaria is the seed of establishment of the US CDC way back, I think nearly 70, 80 years back. And because of that, we have many rich gray-haired, experiences coming up and somehow creating a bottleneck in bringing new innovations. 6 years back, I was a toddler in the malaria field. Honorable Prime Minister, as Harsh mentioned, just announced that India will eliminate malaria. There was no national strategic plan by that time. And I was sitting in a meeting with all gray-haired malariologists. And by that time, Sri Lanka's malaria elimination was very popular. 2012, Sri Lanka eliminated malaria, and everyone was talking about that. Yes, Sri Lanka eliminated, we can, and we will do this and that. And I said that the current strategies don't work, and everyone was frowning. And I had a simple point to say that, what worked yesterday may have difficulty succeeding today, and almost certainly will fail tomorrow. I'm not saying that. These are not my words. If you can see my bookshelf, it's the 4th book in the top right corner. It's Dr. APJ Abdul Kalam. I mean, the god of innovation in India. He said that. And it is true for India. See, malaria is a development problem. If you see Sri Lanka's history, it was development issue there. Malaria was not getting eliminated, and development issue sorted. They eliminated malaria. And wherever you see a development problem, development is a security agenda. So you need technology to fight the security issues so that you can improve access. Now, what do I mean by that? Only two aspects are there where you need technology. The closer we are in terms of elimination, we need more precision. It's like finding a malaria case means finding a needle in haystack. And you need better strategies and also the necessary technologies to implement those strategies. The second piece is, when malaria cases will go down, it becomes a lesser public health problems. And funding and attention will go to the higher burden diseases. And elimination is a costly battle. So you need tools to make it more efficient. Now, how we can do that? First, I'll start with saying that, decision support systems. Everyone talks about dashboards. Dashboards are only front ends of decision support system. You need data integration, you need data visualization and business intelligence to do decision intelligence related to malaria elimination. How and where the resources should be spent. Second, process and service efficiency. There is a new technology called digital twins. What digital twinning is very popular in nuclear systems and many other areas. It just replicates the entire process in a digital way and shows you that whether you can make it efficient through just creating a simulation. That's the digital twin. It's a replica. You need better monitoring systems. I'll just give you an example. People are talking that there are no resources. Only last year in October, I was reading that a company who developed whole body digital twin precision health tool raised a Series C startup funding of USD 140 million. And you are saying that there is no money for technology. And third piece, the hardcore technology that Dr. Gopa and others were saying, not only vaccine. I will talk about G6PD test. Where is it? Pharmacovigilance, high sense RDT. So Anirban was talking about sensitivity of RDTs, high sense RDT. Then, of course, vaccines, newer vaccines. Transmission blocking drugs, the molecules that block the transmission, not only just treat a patient. Semi-synthetic artemisinin, new long-acting indoor residual spray molecules. Your IRS sprays are ineffective. We are still using DDT. We need to go ahead. We need to move on from there. And then for better programming, geospatial tools like OpenStreetMap based tools. And I'm telling you, people are working in malaria. There is a community of OpenStreetMap. It's called HOT, Humanitarian OpenStreetMap Community. And this particular community is already working in creating hotspot mapping globally. Why they can't work in India? The problem starts there. Why they are not working in India is because we don't have a science and technology diplomacy for malaria elimination or a disease elimination in India. India government has made a giant leap. In fact, in the US ISPF forum, I was sitting and listening to Dr. Amitabh Kant a few days back, and I was just amazed with the vision that India government has in their digital transformation. Unfortunately, the science technology diplomacy is not happening. And if there is one word I want to see in the new national strategic plan, will be the science diplomacy committee or science diplomacy group that is focusing on the funding and as well as the new technologies. And funding is not only CSR or government funding. Humanitarian initiatives are there. I told you about HOT. Accelerator fundings are there. Effective altruism communities are there. In fact, in Delhi, the global EA summit will happen probably in next January. And these people are only doing these things for humanitarian purposes. Voluntary initiatives of corporates, corporate gifts, philanthropic gifts. And then you have the conventional resources of different ministries like, Hers already mentioned tribal affairs, and then all other ministries are there. There are CSRs and all different stuffs are there. And of course, the funding agencies, bilateral funders and all. So there is no dearth of resources. It's the intent, it's the awareness and orientation, how we move to it. and how we apply technology. With that, I'll stop.
Oh, thank you so much, Dr. Kaushik, and I hope and pray that government's internal capacities can be enhanced to tap into scientific diplomacy, look at the funds available, and yes, I mean, if all hands are on the deck, as Harsh was mentioning, surely a lot of good can happen. And we have taken a lot of pride. India has always been at the forefront of technology for the world. There's no reason why we can't do the same for India itself. So thank you so much for bringing that perspective, Dr. Kaushik. I now turn my attention to Dr. Rajiv Tandon, who's director with RTI International and a very senior person working in malaria and several other fields in his life. Dr. Tandon obviously, has PV has been a favorite subject of his, but for this particular forum, he's chosen to speak about health system priorities for malaria elimination. So over to you, Dr. Tandon. I'm so sorry that we're running out of time, so we'll have to keep it short as much as possible.
Sure. So thank you very much for inviting me to this very informative session indeed. And as all speakers have mentioned, I mean, it's been a really discussion that, if well captured and taken to leadership, it can actually have a huge impact. I've been asked what potentially health systems can prioritize to ensure all that everyone has suggested. Very briefly, and mine is going to be in no way futuristic, but it's going to be realism. Today, if there is somebody who is a potential person or a patient with malaria at any age, in any geography, at any time of his life or her life, the only potential health system opportunity that that person has is either through the public sector, which is government-led, or the private sector, which is non-government-led. The non-government-led private sector is again basically formal or informal. And how do we define formal or informal? The formal is till today led by people who have got proper trainings, certification, usually is considered allopathic led, though today we are seeing a little bit of mix in the leadership of the formal sector also, is usually profit driven. So the person has to pay for facilities of diagnosis or treatment or complications or whatever. And it could be in the form of tertiary care hospitals, corporate hospitals, it could be nursing homes, it could be clinics of doctors, and so on and so forth. The informal private sector, very broadly, is in the realm of people who are not properly trained, who usually could fit into registered medical practitioners, quacks, Jhola chaps, Bengali doctors, sorry for all these names, but these are people who usually are non-trained people, but are providing healthcare and providing healthcare to a very large sect of population in India, 60%, 70%. There are then within the private sector some medical colleges, which are centers of training and teaching. The medical colleges again could be private or public, and we wouldn't go there. And then by and large, the big elephant in the room is the public sector health system. What is public sector health system? Starting right from the ground, and when I say the ground, I consider the ground either as a village, which is rural, or a ward, which is urban. There are clear definitions between what is a village and what is an urban environment. We wouldn't go into that. So if a person does get a potential symptom that could be malaria, the people who could that person be met or connected to or if it's a village, it's the ASHA, the accredited social health activist. If it is a ward, it could be an urban equivalent of an ASHA. It could be a multi-purpose worker. It could be an auxiliary nurse midwife. And there were times in the past when even the Anganwadi workers used to be allowed to do something, whether it was counseling, etc. What all can potentially happen at that level? And this is my understanding. I'm sure with all the experts, and as somebody mentioned, the gray-haired folks are usually bottlenecks. So I'm sure there are newer innovations and opportunities that could bring in, and we welcome all of that. I think the beginning of the story of enumerating patients with potential malaria happens there. All the outreach services, whatever is the outreach service, these are people who can actually come into your houses. Screening, then assessment of risk. Is it complicated? Is it mild? Is it moderate? Generating awareness. Somebody said social and behavior change communication. Somebody said IEC. Once we have patients who, after discharge from hospitals or clinics, follow-ups with these patients and ensuring treatment compliance. Somebody mentioned about drug compliance, 14 days, etc., etc. These are the people who will potentially do that. Everything that I said that these people can do needs to be done. Unless all of this is done for malaria, we will be year after year back to the discussion that we are having. This community level, ground zero, rural urban connect is then connected to what are called sub-centers. These sub-centers have mid-level healthcare providers, are now going to also have community health officers. This is something that has happened through the Ayushman Bharat initiative. Earlier, this was not there, but now we have these people. These are not people who are ASHAs. These are people with some trainings, some certification, could be what is called Ayush certifications. This is where the first level care happens. So actually care provision happens in a sub-center. Screening happens here. Diagnosis can happen here. So somebody mentioned RDTs, somebody talked of newer and more precision RDTs, somebody talked of challenges of the diagnosis. It happens here. Drugs can be given here. But what's most important is record keeping has to happen here. For us, we've been discussing malaria, numbers, and all of that. This is an area where actual record keeping happens. From here, if somebody, the ASHA, the community health officer, identifies somebody who potentially has malaria and has it with complication, they are supposed to send this person further up to what are called primary healthcare centers. In urban areas, they are called urban primary healthcare centers. There used to be a population norm for these. Today, this norm is completely gone. So what needed to be at a certain level of population, they are having to look at much bigger populations and so on and so forth. It is here where you actually have doctors, you have nurses, you have pharmacists, you have lab technicians, you have computer people, you have a computer, etc. Diagnosis, prescriptions, treatment, referral of complications further above real-time monitoring happens here. And then sort of the top level of public health care provision happens in what is called CHCs or district hospitals. And for the way they are mentioned, they are either at a district level or they are slightly sub-district, but they are much larger. Here you have advanced diagnostics, and a lot of people mentioned about newer diagnostics, use of technology, use of digital, use of geospatial, all that. Potentially, if it could happen, it would potentially be used here. Assessment of complications, treatment of complications, and then link with the tertiary care. Under Ayushman Bharat, there is also something called the PMJAY, which is a community insurance scheme. And the community insurance scheme, which if I have malaria and I have complicated malaria, and if I need actually coverage under hospitalization or expert opinion, etc., the PMJAY actually happens at district hospital levels or CHC levels. Apart from this public and private, which is very broad, and the way I mentioned, somebody talked of the defense services. There's also railways, there's also CGHS, there's also ESIs, there are corporate hospitals, there are missionary hospitals, and so on and so forth. There is no dearth of actually institutions, but there is dearth of, I think, human resource within the institutions. And there is definite dearth of understanding the focus for malaria within human resources and the institutions. So I'll stop there. This was very broad we are running very, very late. I really want to thank the organizers, Malaria No More, and Dr. Kaushik, and all the others for bringing me on board. Thank you.
Thank you so much, Dr. Tandon. I think there's a repeated echo of literally all hands on the deck message that, the health systems, the health systems that typically have not gotten into malaria also joining hands. And unless and until we do that, the elimination battle is a long one ahead for us. And maybe this is a time when all of us do come together. And one of the institutions that also can play a sterile role are the medical colleges. And from there, we have a young Dr. Venkatesh Karthikeyan, who's currently pursuing his MD Community and Family Medicine degree in AIIMS Patna. And he's going to be speaking on management of malaria in medical colleges. I'm so sorry, Dr. Karthikeyan, we are running short of time, but last but not the least, we would love to hear from you. And then, we would like to wrap it up.
Thank you, sir. Thank you so much. So I'll just share my screen. Yeah. So very good evening, everyone. Thank you, Pratik sir. Thanks to all the senior people here for giving me an opportunity to be a part of this panel of experts like Dr. Anirban sir, Dr. Achishman sir, Dr. Rajiv sir, Dr. Harsh sir, Dr. Raghavan sir, and special thanks to Dr. Kaushik sir for this wonderful opportunity. Our panelists have wonderfully highlighted the challenges in malaria management from a physician's perspective, and then how to design a human-centered program for malaria elimination, epidemiological aspects, digital transformation, health system priorities, and few other important topics. They have beautifully highlighted the challenges and discussed the potential solutions as well. I would like to take 5 minutes of the panel's time when discussing few key challenges which I have observed in tertiary care centers like teaching medical colleges. Though many challenges have been discussed, I would like to summarize those in a very quick fashion. So the first challenge that I would like to discuss here is that the challenge is related to the implementation of the guidelines. But before implementation of the guidelines, as seniors have already pointed out, one should be aware of the guidelines first. So we have very concise, beautifully drafted guidelines given by National Vector-Borne Disease Control Program. But are we aware of these guidelines? Are we teaching it to the students? Are we teaching it to the healthcare workers like ASHAs, ANMs, and medical officers? Though there may be guidelines and proper knowledge dissemination, are those guidelines followed in real world scenario? If yes, how well it is followed? Do we have any monitoring and evaluation mechanism for it? If not, why it is not followed? What are the challenges in implementation of these guidelines? What are the solutions for addressing these challenges? So there are so many questions for which we need to look answer for. For example, this is a snapshot from the guideline which I have showed in the previous slide. It says that we should give chemoprophylaxis for pregnant women living in high-risk areas and chemoprophylaxis for travelers who are going to highly malarious areas. Are the healthcare workers aware of these guidelines? You may answer yes with a lot of confidence. But if I ask you the same question, are they putting it into practice? Then the level of confidence will go down. So this is a big challenge. Though we have wonderful guidelines, how well we are implementing it is a question, and this is a key challenge we have. You might ask me, Dr. Venkatesh, you said in the intro slide that you will discuss about the challenges in the tertiary care hospitals and medical colleges, but now you are talking about guidelines and implementation in the ground level. Does it have any relevance? Absolutely yes. If these guidelines are not properly followed by grassroots level workers like ASHAs, ANMs, and medical officers, then what will happen? We know that the majority of our country's population is in rural areas, and ashas are the common point of contact, and the most poorest of poor people go to the PHCs and health and wellness centers first. If the health and wellness centers in the grassroots are not aware of the guidelines and not implementing them properly, it leads to delayed diagnosis, and the patient will ultimately end up in medical colleges with cerebral malaria or some other kind of complication. I am currently doing my research on capacity evaluation of health and wellness centers and PHCs of Jahanabad district of Bihar. I visited a PHC yesterday for data collection, and the photo you're seeing, this is the sad state of the PHC. When not even basic infrastructure is proper in our country, how can we adequately give primary care? And I also noticed that last week when I went to a health and wellness center, I saw a locker. In that locker, there was a brand new box, fully sealed. And when I opened it, I was surprised to see box of malaria rapid diagnostic kits. Since the day of start of this health and wellness center, not even a single kit is used. Does it mean that there was never a case of fever in the history of that locality? No, I don't think so. We keep complaining of lack of resources, but we don't focus on appropriate usage of the available resources. Like this, when primary care is not given properly, patients end up lately at tertiary care centers with advanced diseases, which makes management of malaria a challenging one. The next thing I would like to discuss is about the challenges related to referral. This was the referral hospital for the PHC, which I have shown in the previous slide. Beautiful building, but the building has only one doctor, 2 to 3 staff nurse, 1 lab technician, 1 pharmacist. So again, here, lack of manpower. Early diagnosis and prompt treatment might be affected because of it. Even if the doctor is identifying the malaria symptoms promptly and giving basic treatment, referring the patient to higher centers like AIIMS or some medical colleges, when the patient lands up in medicine OPD, what will the patient have in his hand? We expect him to have such a well-drafted, beautiful medical referral letter like this. But consider the manpower, consider the patient load in that referral center and other factors. It would not be possible to receive such a well-drafted referral letter. Leave the word well-drafted. In many cases, we might not even get a referral letter. So how the consultant sitting at the medical college know the proper history of the patient? How was the patient confirmed? How was the patient confirmed for malaria? What was the technique used for confirming the malaria? What was the treatment given for the malaria? So these are the questions for which a consultant sitting in medical college would not have any answer. So these are the few key challenges with referrals, and this is a definite challenge in management of malaria in medical colleges. So discussing our next challenge, how many of us are filling this malaria reporting form after treating the patients of malaria? A better question to ask would be, how many of us have seen this form in the first place? Where can we get this form? We are more interested towards managing patients who are sitting in front of our eyes, and we don't care much about the bigger picture. In other words, our physicians are not used to see things with a public health point of view. Hence, we do not give enough importance to fill this malaria reporting form. And when we are not communicating this to the concerned authority, when the medical colleges or the tertiary care hospitals are not conveying this information, not reporting malaria cases to the concerned authorities, it will be a barrier to detect an outbreak and to take essential preventive and control strategies. When we people at medical college do not do it, thinking that we guys are busy and we do not have time, then ultimately the number of malaria cases in the community would rise and more number of cases will eventually come back to us only, thus straining the already scarce healthcare resources. How well are the teaching hospitals prepared to handle these outbreaks? I leave this to yourself. Hence, we should train and motivate our interns, postgraduates, and faculties to report malaria in a timely fashion, and this task is a definite challenge. Have we seen any kind of, coming to the next challenge, have we seen this kind of any written protocol for the management of malaria displayed in the wards or ICUs or anywhere? Not everywhere. And how to manage if there is a case of malaria outbreak and your hospital is getting more and more of malaria cases? Not everybody of us knows. But ideally, written protocol should be made available wherever possible. And we generally have experienced consultants in medical colleges, like Dr. Anirban sir was discussing physician's perspective. So me talking about the in-depth about the management of patient in medical colleges won't make great sense at this point of time. So let the consultants with their expertise, with whatever degree they have, whatever experience they have, let them treat the patient. Let them diagnose the patient, let them treat the patient, let them prevent the complication, let them help the patient recover and send the patient home. But what next? What is going to happen next? Do we have any mechanisms to follow up these patients? Do we have any mechanism to track these patients? Like Dr. Kaushik sir was saying in his presentation, do we have any beautiful dashboards to show us the status of malaria? In my limited experience of working with a few institutes, I have not seen such things put into practice. What to do if a patient develops some complications post-discharge? What if he has a relapse? What if his family members develop or his neighbors develop? So we don't know answer for all these because we do not have a mechanism, a robust mechanism to follow up the patients. So this challenge has to be promptly addressed. We should devise standard mechanisms for following up malaria patients, and that SOP is to be put into day-to-day practice. We have primary health centers, primary healthcare centers, and secondary healthcare centers to treat the patients of malaria. We have research institutes like ICMR to do research on malaria, but both these can happen together only at medical colleges. But despite that, we could not see much emphasis as being given to research. In better terms, the significance of research is not felt by us as residents, as interns, as postgraduates. Okay, we focus either on clinics or we focus on academics. We tend to miss out that there is a component called research. Essential steps should be taken to promote in the medical colleges. One such example is ICMR STS and ICMR MDM thesis grant given by the Indian Council of Medical Research. I was lucky to receive this thesis grant to be one among 50 in the country. But in a country like India, where there are several hundred medical colleges, giving these 50 grants, giving grants for 50 researchers, 50 PG students, do you think it is sufficient? So like this, more research in medical college, especially in important areas like malaria. This will include good diagnostic facility and the potential to carry out hundreds of research projects every year. So these are the few challenges I have observed in my limited experience. I would request the panelists to add on if there are if I have missed out anything else. Thank you so much.
Thank you so much, Dr. Venkatesh. And as probably the only person who's not really a doctor on this panel, I'm actually stunned and amazed at the candidness of the thoughts that were being presented here. This kind of and by the way, I'm from Bihar, Gaya, Jahanabad. So believe me, I can assure you there are worse off cases. You had bricks and walls and doors there. So yeah, sorry to be presenting the other extreme. But having said that, we are actually at a cusp where we have this lofty target in front of us that by 2027, the Honorable Prime Minister, and thank you, Harsh, for repeating it 3 times. I don't know, that was a wonderfully orchestrated move from your side and really, struck us deep. And that's something that, all of us have to be really looking forward to. And this repeated echo of all hands on the deck. So whether it's the medical colleges or the private practitioners, and thank you, I'll repeat Dr. Venkatesh and Dr. Narimba and the way the candidness of you, in terms of how and why the health system is kind of missing out in terms of prioritizing malaria within your own ranks and what needs to be done differently. Is absolutely, it's kind of staring on our face, but we're not able to put it together. And I sincerely hope with, the likes of Dr. Kaushik, Dr. Gopal, Dr. Tandon, Harsh, and others, we really managed to emphasize this in the new strategic plan that is being drafted as we speak. And this particular World Malaria Day, the 125th, which itself is a significant milestone, if you look at it, really should be telling how India needs to fight this elimination battle. And we are capable, and we have done it for smallpox, polio. I mean, there's a host of diseases that were far more complicated that we won over. This is possible. This is possible within a lifetime, within a short span of time. And that's something Malaria No More always aspires to do. And I guess, the panelists coming together, I'm sure, Clarnet and Dr. Kaushik will do a good job in assimilating some of the thoughts that have come in together. So thank you so much for your time. Thank you for arousing people like me who are not doctors and who continue to learn from people like you as to what needs to be done differently. There's a whole bunch of questions that have just been sent by Dr. Venkatesh right now. I think we'll have to find a way to, address these questions at a later date. And I'm sure the panelists would be happy to address if they have been directed to particular people as much. And let this be a beginning of a conversation where we all come together passionately to achieve that one big goal, that what needs to be done by a country like India to eliminate by 2027. So even if it does not really happen, what can be done to set the systems right? Most of us have answers. Most of us believe that it can be done. And all of us have given enough pointers as to what needs to be done differently. And with the political commitment shaping up at the highest level, I see no reason why India cannot really transcend that Rubicon. With these words, let me end this conversation here. Thank you so much for your time. It was a pleasure having all of you here with lovely, candid thoughts. Please continue the conversation with exactly this candidness, whoever you speak to. Believe me, because there is still a lot of resistance to what Kaushik kept referring to. The old school is not yielding as much, and we are still resistant to new ideas. And that's where we all come in. We need to push that agenda hard, because the new order will not accept what worked earlier on and will definitely not work in the future, as APJ Abdul Kalam managed to say a long time ago for all of us. Thank you so much for your time. Thank you so much for your wisdom. We'll all be learning and we'll all be doing better. Jai Hind.